is Dr. Niti Jojo. I am one of the junior doctor practicing in the UK and I'm interested in the endocrinology. So today I would like to share health knowledge regarding the bronchial neuroendocrine tumors or carcinoid tumors, which is one of the rare endocrine cancer can happen in our body, and I would like to share knowledge regarding this topic. First of all, what is neuroendocrine tumor? So tumor means it's a mass, abnormal mass. So where it is rising from the cell, which normally produce hormone, so what we call the endocrine cell, and in case of response to the signal from the nervous system. So the tumor or abnormal mass arising from these cells we call the neuroendocrine tumor. So this is an abnormal mass. The tumor produces the higher amount of the hormone than usual normal, and these higher amount of the hormone can causing the clinical symptoms in the patients. So sometimes the tumor can be benign. Benign means it's not a cancer, or sometimes can be the cancer malignant. So the interesting part is these cells are not belonging to one organ because these endocrine cells are scattered throughout the body organs. So we can see in the different part of the body organs of this tumor. So where is this tumor can occur? If you can see, this is a green cycles are showing the primary site of the tumor. So this is a small intestine. So in small intestine, the neuroendocrine tumors are mostly happened. So it's 55%, and this is a lung bronchus. That's what I want to emphasize on this slide. This is a second common cause organs of the neuroendocrine tumors. These are the other organs such as pancreas, small intestine, and some lymph nodes. So these tumors can have mostly happen in these organs. The white cycles are the areas of the spreading tumor. So these are not primary sites. So because of this primary tumor, they're spreading to the lungs or liver as well. So what is bronchial and neuroendocrine tumor, where it can happen? So you can see that this is a main air pipe, so we call the trachea, and then if the trachea going down, we call the bronchus or airway branches. So the bronchial and neuroendocrine tumor happen in somewhere in this airway area, so rather than the other lung tissue. So how many types of these carcinoid tumors of the lungs? Basically, there is only two types. One is typical or low-grade carcinoids, or second is atypical or intermediate grade carcinoids. So if you can see that in typical low-grade carcinoid, it resembly look like normal cell and they grow very slowly. So which means though they are not quite serious in the real clinical setting. So if you see the atypical intermediate grade, so the cells are more abnormal, more larger than the normal, and they grow rapidly and spread rapidly. So it can cause more serious problems in the patients. So how common it is? So basically, these lung tumors, bronchial tumors, is 20 to 30% of all overall neuroendocrine tumors in the body. So if you see the annual incidence, so it's quite rare compared to the other types of cancer. It can happen 100,000 population, in men only 0.2 and women 1.3. In terms of the annual incidence in both men and women in other study, United States surveillance studies, it's just showing 1.49 per 100,000 population. So in summary, it is quite rare tumor. So what are the risk factors? So actually the specific risk factor is not found. The smoking sometimes is the association pathway is unclear, but 2/3 of the patient with these tumors are smokers, and also this is all. And in the smoking patient, the higher prevalence of this more serious type atypical tumors, and in the average age, it can happen around 45 years of age. So the question is it familiar? So for the most most of the cases it is no, it is a sporadic type. It can happen suddenly with no other reason, but in very rare case it can be associated with the familiar disease, what we call the multiple endocrine neoplasia type 1. So what is multiple neuroendocrine neoplasia? If you see the names, this is multiple, so it can affect in many organs, and endocrine is a hormonal producing organs, and neoplasia means a cancer. So this is a cancer happen in the most many endocrine organs. So this is a heritable disease, and the nature is autosomal dominant. What this means, autosomal dominant means it 50% chance of the passing this abnormal gene to every child if the person carrying that genes. So there are major two types, depends on which organs are affecting. It's a type 1 and type 2. So in type 1 you can see that this is a pituitary gland, pituitary hormonal glands, and this is a parathyroid glands. These are the hormonal glands, and this is a bronchial carcinoid. That's now I'm talking about these tumors, and this is a pancreas, duodenum, and small intestine. So these areas can happen in the type 1 multiple endocrine neoplasia. And when you look at the type 2, if you see there's some oral mucosa problem and thyroid cell as well, and adrenal gland is a small hormonal gland just above the kidney. So in type 2 these organs can affect it. If you see the parathyroid gland, it can affect in the both types. So why it is important, if in your family members if there is problem in these organs tumors, so it is quite important to have a family screening to look out for the other causes of other tumors in the body. So, how these cases can be present to our clinical setting? So, it can be divided into two portions. So, one is the symptoms regarding the MUDS effect or tumor effect. So, you can see that these tumors are in the proximal airway. So, it can be present with the obstructed tumor. So, if the airway obstructed with the tumor mass, and so it causing the wheezing, coughing, so sometimes they can be mistaken with the asthma diagnosis. And these tumors are highly vascular, so many blood supply, so they can be present with the bleeding, hemoptysis means coughing up of the blood. And also because of the tumor, patient can suffer pain, chest pain. And if there is some recurrent pneumonia happening in the same segment or lobe because of the tumor is obstructing in the airway. So these symptoms are tumors or MUS related symptoms. So in another part is because of the hormone, as I explained to you before, these tumors also produce large amount of the hormone. So because of the hormone, it can be the symptoms like high hormone, cutaneous flushing, diarrhea, bronchospasm, meaning the narrowing of the airway due to the spasm of the muscle in the airway. So this is a short-term symptoms. If the patient exposed to high hormone amount in long term, it can happen like venous telangiectasia, means some distant veins in the legs and in other parts of the body. And because of it affects the heart valve has been destroyed, so can be present with a heart valve disorder. So this is a stenosis of the heart valve, and this is the regurgitation. So all these symptoms can happen because of the damage of the heart valve, and also the because of the high hormone exposure. Sometimes fibrosis means scarring in the internal organs and other sides. So these are, if the patient exposed to long-term high hormone exposure, these symptoms can happen. So basically two types of the clinical presentation regarding these tumors. So other clinical features is simple because of the abnormal hormone production. So we call the Cushing syndrome. This is an abnormal hormone cortisol production in the body, so causing the abnormal fat distribution, so central obesity, moon face, and also the thin skin and and some easily bleeding. So this is because of the high cortisol hormone in the blood. And another condition called the acromegaly, this is a high growth hormone production in the body. So patient can present with the large hands. So you can, the photo can be different, the size of the jaw, face becoming enlarged. So when we compare to the older photos, so it can quite distant. And the other part of the body, so many condition like high blood pressure, spleen, so and cardiomegaly, so enlargement of the liver. So all these organomegaly and this body side becoming because of the increased growth hormone, this condition we call the acromegaly. So these patients can present with this sort of symptoms as well. So how do we get the diagnosis and how do we work up for this condition? So basically the first diagnosis with the imaging. So we can use the chest x-ray. Chest x-ray is not quite specific. We can use a CT scan, computerized tomography scan. So we can exactly see the tumor location and if there is any other spread to the other body. So this is another special imaging used in these conditions, what we call the somatostatin receptor based imaging techniques. What normally do, so this somatostatin receptor is mainly present in the tumor. So if we look at for this receptor, so we can see the through this imaging, so we can see this these tumors quite easily in the body. This is a whole body scan, so we can exactly know in where area of the body the tumor can happen. So in the blood test, we can do the urinary 5-HIAA chemical. So what is it? This is the N hormone of the serotonin. This is secondary to the high hormonal, showing the high hormonal production in the body. So we can detect in the urine. And another peptide called the chromogranin A. So this is actually this is not to use a diagnosis. Is we can use in the to monitor the disease condition if the patient have a treatment or that sort of thing. That's not quite useful in the initial diagnosis. So another, we can have a tissue diagnosis through the, you know, the tumor in the airway. So we can easily sometimes get through the scopy camera test, and we can get the tissue biopsy. So we can know the diagnosis clearly in this way. So what are the treatments? So if we know the diagnosis, the treatment depend on the staging. So if it is only the tumor is only the local area, no other spread, so the surgical excision is the mainstay of the treatment. Sometimes depends on whether the lymph node involvement or not. The surgical can be through whether the lymph node excision or not. And other therapies such as the platinum-based chemotherapy, radiation, and another thing is that because of the in the airway, we can do the if the tumor is not spreading and quite small, sometimes we don't need an open surgery, so we can do the endoscopic bronchial resection. So it means that through the camera test and surgery, laparotomy surgery, we can take it out the tumor. But sometimes if the tumor is different scenario, very spread and enlarged, we can't take it out. So through the scopy test, we can give the some therapy to slow down the tumor growth, so it can relieve the obstruction. So that sort of things we can do. So other inoperable tumor is spread a lot and tumor cannot be taken out. So we can do some radiotherapy to relieve the symptoms, to control the tumor size. So if the patient having the symptoms regarding the high hormonal production of the tumor, so we call the carcinoid syndrome. So in that situation, what we're doing, so if the tumor is like potentially to be resectable, so we will do the surgical excision. If not, we can give some medical therapy to relieve the symptoms, such as a somatostatin analogs. This is a normal hormone that's normally inhibit these hormone in the body. So the somatostatin analog, this is a synthetic hormone to control these abnormally high hormone levels in the body. So if the patient is having refractory symptoms happening again and again in this condition, we can do this. If there is liver lesion, so we can do ablative surgery, means some interventional therapy we can give some injection or some therapy to slow down the tumor side, take it out to do destroying the tumor tissue. This is called ablating surgery, or some medication telotristat. It is just kind of medication to relieve the hormonal symptoms, or this is another medication everolimus. This is an anti-cancer chemotherapy medication. So these are the quite specific medication we can use in this condition. So, what's the prognosis? So, as I explained to you before, it depends on the type of tumors. So, the low grade typical tumors are very good prognosis. If you can see the 5 year survival rate, we can have 87 to 100%. This is quite good. This is quite manageable, nearly curable. And 10 years corresponding rate is 82 to 87%. But when you look at the intermediate atypical tumors, the 5 year survival rate is about only 35 to 95%, and 10 year corresponding is 35 to 56%. It is quite different. So it normally it depends on the type of tumor, and it depends on the treatment advantages in this condition. So we can manage the patient according to their clinical condition. So this is, thank you very much. This is end of the slides, and really appreciate your listening to me. Hopefully it will help. This is kind of knowledge you gain from this slide. Thank you very much.